Mletzko Alzheimer's Disease Research Center is bringing you this 1 hour long program where we're sharing great tips on brain health and just how you can improve your overall health, whether you're a provider, a clinician, a therapist, or an older adult that is concerned about memory impairment, or perhaps you have been diagnosed with memory loss and you want to keep what you have. Perhaps even you are a caregiver for someone, and during a pandemic, that stress of being a caregiver for a loved one, along with all that's going on with the pandemic, this is an opportunity for us to give you some tips and strategies and some insights about what we're doing as a disease research center, but also what are the latest discoveries and findings that our center is in pursuit of. Our ultimate goal is to find a cure for Alzheimer's, and we're working with experts from around the country, around the globe actually. And right now we have over 40 active trials, and if you've been with us since March 31st, you've heard about many of them. And you're going to hear from two of our faculty today, along with Dr. Ken Hepburn. So again, welcome. It's 2 o'clock. Thank you all for joining us. Take time to participate in the poll. There's also a participant satisfaction survey, and we've heard from about 25 of you already. So thank you so much for your input. We take heed to everything you say, and we appreciate you taking the time to join us every week. Every Tuesday, we're online via Zoom. In the past, we have always hosted these really nice, robust, high quality, informative programs in person, but again, because of the pandemic, we are meeting with you virtually. So today you're going to hear from Dr. Ken Hepburn. He's going to be sharing information about signs of caregiver stress. We talked about stress. We talked about managing your person living with dementia. We've talked about Medicare visit. We've talked about getting your annual wellness visit. What are the preventative services? We've even had guests come on talk about their experiences with mental health. So today, after Dr. Hepburn talks about signs of caregiver stress, you're going to hear from Tanja Mletzko. I'm sorry, Tanja. She's with our Emory Mood and Anxiety Disorders program. She's going to be giving us an update on signs of depression and certain interventions that their center is currently hosting. And then followed by Tanja, you're going to hear from Glenna Brewster. She's going to be talking about interventions for the Dementia Caregiving Dyad. So that's a mouthful. So right there, you're going to be hearing from 3 of our faculty who will be sharing a lot of insight in this short amount of time. Then we're going to close out with Whit Morgan. Every week we've been talking about our Healthy Aging study. It is a worldwide study. The last question on the participant satisfaction survey asks, have you ever participated in research? And half of you answered yes. So that is very encouraging. Right now for Alzheimer's, there's not a cure, and research is our only hope. So if you are actively engaged in any type of research, we commend you, we thank you. And again, if you have comments or questions, the chat is open. So we want to welcome you again. And with that, we're going to turn it over to John. We begin every week with an exercise demonstration, because as we say every week, what's good for your heart is good for your brain. All right, take it away, John.
Hey, hey, hey! Y'all ready?
Red light, green light.
Okay, y'all watch my mouth.
Everybody take a shot. Red light, green light. Give me everything you got. Red light. Listen to your fast.
There we go.
So ride and lunch money. Three Miami boys. You know what time it is.
Give me the green light. Cause I'm ready to go. Let's have a good time.
There we go. Give me the wheel. Look at that line.
We only got one life. And we gon' live it up. So give me the green light. Cause I'm ready to go.
Come on.
mommy, and you know what that means. So we can do anything that you dream. I'm gonna make you ooh, till you scream. And that's what I preach, if you know what I mean.
Red. Watch it now. I need you.
Yeah, we can roll and I'm gonna rock that, mommy. I do what I say and say what I mean. Now let me jump in between. I'm getting loose in this thing, like OJ and juice.
Give me them here. We working on this right now.
I got all the women getting up, feeling like Luke in this thing. That's the game. Now I got the green lick and the green light. I need this money for you to give me the green light, so I can run through it like an easy pass.
Okay, Red. Let's all play.
Give me the green light.
Come on.
Cause I'm ready to go.
Let's
have a good time.
Let's have a good time now.
What you waiting for? Only got one life.
Come on.
And we gon' live it up. So
Watch it now. Watch it. Watch it.
Cause I'm ready to go.
Come on.
I got the lightest, I'm gon' ride it. You know I'm all about that beat.
Break your leg down. We get those hamstrings.
Turn green, give me what I asked for. I got a passport.
Come on.
International before I hit the airport.
There we go. Ow.
Every yellow do we got
And red.
I like the cleanest, leanest, I'm the Venus. Give me the green light. Give me just one.
We gonna keep that cardio going and bodies go
right
big.
now.
Here we go.
I'm ready to go right now.
Let's go. Oh, let's go. Let's go. Oh, let's go. Oh, let's go. Oh, let's go. Oh, let's go. Go, go.
I see you move, I'm checking your slide. Working your back like it's not out of style. Shake just a little bit faster. Shake just a little bit.
Other leg. Let's go.
Tired to meet you, so let's mess around. I've got a new session, the club's getting down. Come
Pick it
just
up,
a little
pick it up,
bit
pick it up, pick it up.
closer. I just need permission, so
Good job. Watch out. Leg wide. Watch.
ready to go right now.
We get that waistline. We get those hips. I just want y'all to feel good. Ow.
Ready to go right now. Ready to go.
Can I just get one leg? One leg.
Green light, it's what it seems like. The way you moving, baby, lets me know that this won't be right.
Green. Let's go.
I want to green red light. I want to see what you get.
Let's go.
If I be your buddy, get you study, it's your head right.
Good job. Woo! I'm not gonna let y'all work me today. I need that waistline now. Here we go. Hands out. Whoa.
Baby, that's my name.
Woo! Come on now. I need that waistline.
That's how I got my name.
I hope y'all not gaining weight over this pandemic.
That's gonna understand what this man feels so beautiful. Ooh, they call me Mr. Telephone.
There you go.
I know someone just like you.
Other side. Other side. Let's go.
Like this, everybody knows. They call me Mr. Telephone. Most every place I go. But nobody seems to understand. I can imagine saying such a sad song.
There we go.
Ooh, we lost everything.
Can y'all lean forward? You feel about that waistline?
I cannot explain to you.
No.
So very beautiful. I cannot tell you about
Oh, red.
all things.
I'm just over here having fun. I'm just over here having fun. I hope you having fun with me. Y'all ready? I need down. Bring 'em. There we go. Oh, let's go. Let's go. Let's go. I need y'all to shake it. 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 Oh. Oh.
Keep on. What's your name? Hey. Doctor. A ring-a-ling-a-ling. Honey, shaking is the greatest thing. But if you're really wrong, shake it with all your
Keep that waistline going.
do it right now.
Go.
Put your hand on your hip.
Let's go.
Honey, you let the backbone flip me. Move your body like those hips.
Oh. Woo. Hey. I want to say to y'all, I'm glad y'all had fun with me today. I need everyone to make sure they challenge themselves and say, I love this temple, and do something great for that temple every day, because it is a gift. And make sure y'all just go do the survey, because we really want y'all input about what we need to do for you and what we can do for others and caretakers. You can do the survey as well, because we're really concerned about helping and making sure we get the information out to you. I'm John Lewis, and see you later. Bye.
Hey. All right. Thank you, John. We love his energy. We love having him on every week. It's such a joy. Thank you all for joining. We see all the comments. I hope you guys have been up and moving and getting your heart going. We always like to start with that physical activity to get your brain going so you can get ready to take notes. We cover a lot of information in a very short amount of time. And just keep in mind that these are like guideposts. This is not a lengthy, full-blown presentation. Any of these presentations could turn into a day-long lecture. We just want to give you some guidance and help you towards a better path to brain health, okay? So if you need further clarification, we always tell you to first see your doctor, talk to your specialist. And with that said, we're going to turn it over to Ken. Oh, one announcement. So next week is Labor Day. We are still going to have Brain Talk Live, except it's going to be with a little twist. So John will come back on. And then last week, if you joined us, we brought up immunizations and vaccines and things that older adults need to take care of. So we've reached out to the DeKalb Board of Health. And so one of their experts is going to come on next week and just sort of explain that vaccination schedule for older adults for us. And then for the remainder of the program, we're just going to have a little fun. If you guys want to turn your cameras on, if you want to chat, we're going to play a few games for about 30 minutes and just kind of let our hair down and play like Name That Tune and some trivia, or you can send in some suggestions if you have some, and we'll take those into consideration as well. But we're still having Brain Talk Live next week. It just won't be with all of our experts. We're going to feature one topic. We're definitely going to do exercise, and then we're going to have a little fun, okay? All right, so take notes. So when you get the link to register, we want to see you all back with us next week. I see we have about 200 people on, so let's get started. I hope you have your notepad and you're ready to go. Here is Dr. Hepburn, who's going to be talking about stress.
It's hard to talk about stress after participating with John, but I think it was a topic that was brought up in the chat. And it's an obvious topic to cover during this time of sort of intensity with this surrounding the epidemic and all the social realities with which we're all faced, not to mention the upcoming election. So a lot of reason to be stressed. I put together a few slides, and I think that this is going to tie in with some of the other presentations today. So there's a nice sort of dovetailing of topics. So Cornelia, do you have my slides, or do you? Yeah. there you go. Okay. So we want to talk about recognizing and dealing with caregiver stress. And I think I put it in this order because I think it's really important to understand that this is a little bit like the way in which you cook a lobster or a frog, right? Stress is you're in the pot of cold water and the heat is turned on and you kind of don't know what's going on until suddenly you're boiling. So the idea of recognizing stress, I think, is really a terribly important precursor, first step to actually dealing with it. So next slide. So I want to remind you of a slide that we showed quite a while ago, and this is a fundamental process that almost every clinical discipline teaches to its most novice members. And this is the way in which clinicians kind of go about their business. First, they assess a problem. They don't just jump into something. They sort of look at it and try to figure it out. And based on what they understand about the problem and about other kinds of things, they create a plan for dealing with the problem that they think is the best plan for solving that problem. And then they put it into play. They implement the plan and see what happens. They evaluate it. When they see what happens, they learn new information about the problem, and it helps them to reassess if necessary. So I want you to keep this in mind as we go through. I want the first thing to do is to act like a clinician, to think, what is it I'm seeing that might indicate stress? And the first way to think about it is in what ways is what I'm seeing different from what's usual? So, and only then, how can I make a plan? So if we go to the next slide. So first, assess the situation. Are you in fact stressed? Are you in that pot of water that's heating up and coming to a boil? So next slide. So some common signs of stress, and I think our next speaker is going to speak much more in depth about this, but think about noticeable changes. So in the way you behave towards others, your demeanor. So it's somehow the way you're interacting with people different from the way you usually do. If you're usually kind of cheerful and pleasant with people, do you continue to be that way, or do you find that you're becoming a little sharper with people? I mean, you may be the kind of person who normally is kind of cool to people, and if you're cool to people, that doesn't represent a change. That's not necessarily a sign of anything, it's just you. Is your energy level changed? If you're my gosh, if John Lewis ever stepped down a notch, everybody would worry about him, right? His energy level is incredibly high. Mine is sort of mid-level. If it suddenly rose or if it suddenly slumped, I would notice that's a change. So is there a change in energy level? Am I sleeping or eating more or less? Am I enjoying things that I used to enjoy less? Is there some way in which I don't want to do that anymore? I don't feel like it. That sort of drop off in enthusiasm for things that you care about is a sign of stress. Are you able to get involved in things and to stay involved, or are you easily distracted? And a fairly straightforward sign is that your anxiety level. Are you just more anxious? And this one, I would say, if you're noticing a change, an increase in anxiety, that's stress. Or are you feeling uncharacteristically down or sad? You may be a pessimistic person in general. And if you're still pessimistic, but no more so, that's not any change. Are you feeling hopeless? Do you think, well, geez, nothing's going to work out? Are you discouraged? Are you discouraged about everything I try is just not working? Do you feel withdrawn or apathetic? Do you feel like, I just don't want to be involved. I don't want to be engaged in anything. You feel useless. Again, has your anxiety level changed? Are you feeling pressured? All of these are signs. So if you're recognizing, if you're seeing this, then go to the next slide. Think about try to identify the sources of stress, okay? I want to show you another slide that we showed a couple of weeks ago. And this is this image of everyone has a comfort zone. All of us have a comfort zone. We can, whether it's we have a high tolerance for stress or low tolerance, it's a zone that we live within. So are you changed? Are you changed from your baseline level of comfort zone? Because increasing levels of stress shrink that zone, and it means that you are much more susceptible to just reacting, blowing up because you're overly stressed, or potentially just withdrawing, pulling into yourself because you're overly stressed. If your comfort zone is shrinking and the stress is increasing, you may find yourself flying off the handle or withdrawing or just being unusual in the ways we talked about. So all of this is a way of sort of sensitizing you to your stress level. So if you assess your level as being stressed, then next slide, then think about doing some things. There are some obvious possible sources of stress. You could have increased caregiving demands on you because the illness in the person for whom you're taking care could be progressing, and the demands are harder. There's more to do as a caregiver because the person's strengths are fading, and you have to supply them. Your situation could, like all of us, be affected by COVID-19. By the threat of the illness itself. I mean, everybody is living with a certain kind of level of what if I get it kind of stress. But also, if you're in a caregiving situation, that situation is being changed by all of the restrictions and cautions and care that we're taking to keep ourselves and our person safe. So this is just a higher level of being on guard. And then, of course, life goes on. So things are still happening with your family, with work, finances, with, just stuff in the world. So if you're feeling stressed, think about what could be some of the causes of stress. So this is all part of the assessment piece. Next slide. And then when you've done your assessment, what steps can you take? So this is what kind of plan can you create? And this is kind of almost as far as we're going to get today. But so one plan is, if the stress is based on day-to-day care load, could you possibly find ways to ease that load? Not like you can go out and send somebody to adult daycare, or that there are respite programs open. That's just not happening. So, is there anything the person could do by herself? You could still be in the house, but in a different room doing something. But is there a TV program? Is there something on YouTube? Is there music? Are there puzzles, handwork that the person could do by himself? 2 quick stories. Love this one. The caregiver whose husband, I think I told this before, went to one of the big SEC football schools. 2 or 3 times a week, she plugs in a videotape she has of his alma mater trouncing the arch rival in football. The guy will watch it over and over again by himself, and she can go off and do something. I also once interviewed a caregiver whose husband had been really good at jigsaw puzzles, and she could put out and he had progressed, his dementia had progressed, but she could put out a fairly complicated jigsaw puzzle, and he would spend an hour or 2 a day on that by himself. So is there anything a person could do safely while you could do something else? Or can you engage a family member, some friends, or the church community in coming in for a brief period of time. Now, you'd have to set up all the infection control protections to bring somebody in the home. But if you can bring somebody in and guarantee that there's a sure thing activity that person can help your person through and with, while you go in another room or even leave the house for an hour or 2 hours, be willing to try that. If you've got an activity that you know works and works really well, and you know how to set it up, get your person engaged, and keep that person involved, teach somebody in your family and your friends and your church group, community group, to do that and come in and do it. Try it once. If it works, try it again. Maybe you can expand it. And then identify a things for you list. So what do you like to do? What do you do for yourself to blow off steam? What do you do for yourself to relax? What do you do for yourself to treat yourself? So actually write this down. Write down a list for things I do. Maybe some of them you can't do, but there are some things that are going to be feasible. And then have a fairy godmother exercise. Think to yourself, if I had 15 minutes to myself, what could I do on that list? If I had a half an hour, if I had an hour, what if I had an afternoon? What if I actually had a day? Make a list of things for you and then match it against those kinds of times. And then if you can get the person involved by herself or have somebody come in for however long that time is, pick something from that list and do it. If it means, doing your nails, or in my case, trimming my beard, do it for you. Okay, so then the next and I think last slide is see what happens. Try it, see what happens. If you're successful, and that is to say, if you feel less stressed, how can you do it again, longer, more often? How can you do other things on your list? And if not successful, that's okay, you've learned something. Why do you think it wasn't successful? That gives you information. You can replan and try it again. So I think that may be what I got. Let's see. Yeah. So make out a list for yourself and the fairy godmother exercise. Match those two and see if you can get yourself, spring some time for yourself. So thank you.
Excellent. So Ken, what can if a person is feeling guilty about even just taking those 30 minutes, how do they just get past that? And
I will give you absolution. Everybody's going to feel guilty about stuff like that. I think there's a matter of acknowledging that you've taken on a tremendous load, and it's over and above, kind of way beyond this call of duty. Even in the case of a spouse or daughter, it's not what you signed up for. This is a different role. So you are now in a clinical role, and you're acting as a clinician, and we tell our clinicians all the time, you're the instrument of your person's well-being. You have to care for the instrument. So I don't think it should be guilt. I think it should be a feeling of accepting the responsibility and celebrating that you're actually acting responsibly.
Sound advice. Okay. All right. Well, moving on to our next presenter, and I want to remind everyone that this session is being recorded, and the PowerPoints will be available if we have your email address. Okay. Welcome, Tanja, and I always butcher your last name. I'm so sorry. Are you on? Let's see.
Hold on. Do you want to start the video? Because I can't, because you blocked me starting the video.
Yeah. Do you want to start your video?
Yeah, so people can see it.
Okay, go ahead. And then if you could come a little closer so we can hear your audio a little better.
Okay, I can probably increase it. Is this better?
A little louder. And every one of you can just give us a thumbs up or raise your hands if you can hear Tanya. Okay.
Is this better? A little louder?
Maybe it's my volume.
Okay, I can talk a lot louder too. I have little kids, so
Okay.
all right.
I would get a little closer. Yep.
Okay, all right. So, my name is Tanja Mletzko. I am the program manager for the Mood and Anxiety Disorders program here at Emory. And basically, we study what Dr. Hepburn talked a little bit about, the stress. But we are talking about stress when stress is, and you need me louder. Let me just see. So I think I'm talking as loud as I can.
Okay, that got better.
Okay.
Yeah,
I
that's
don't know what I
Great.
did, but I did something.
Okay, that is perfect. Don't move.
Okay. All right. All right. So I'm Tanja Mletzko. I'm the program manager here at the Mood and Anxiety Disorders program at Emory. And what we do is we look at when the stress that you have, that everybody has, you know, in varying stages. We have a lot of stress right now because COVID just, you know, put all of our lives in disarray, and we are basically picking up the pieces, and that can be very stressful. And so what happens when that stress is not staying with you for 2 or 3 days but for weeks on end? And that's what we actually call depression. So feeling sad or feeling stressed, feeling disorganized, feeling anxious for a couple of days is completely normal. What we're talking about when we talk about depression in a psychopathological way, in like in professional terms, is when we talk about depression staying for us for a long period of time. And you can go to the next slide. Yeah, just click the forward button. So basically, we are looking at the biology of psychiatric disorders, and go to the next one. And we look at treatments, of novel treatments that have not been approved yet for psychiatric disorders. I'm going to talk about depression in particular, but we also venture out into complementary and alternative treatments. So we did massage therapy for anxiety disorders. We did massage therapy for patients who've had prostate cancer. We've had massage therapy for patients who had breast cancer, and we would see whether the stressors that those patients experienced after treatment would actually be modified by getting massages. And there was 2 different massages, but go to the next slide. This was what I was talking about. So when we talk about depression in a psychiatric term, we talk about you need to have 5 of 9 symptoms most of the day, nearly every day. Okay, and that's important because not everybody gets a diagnosis of depression, because that might be just a natural reaction to naturally occurring events, just like the sickness or illness of a loved one, or us losing a job, or COVID. But what we're talking about is that this depression does not leave you. So you have a depressed mood most of the day, nearly every day. You have the loss of interest. You have the guilt that Cornelia was talking about, but it wouldn't leave you. The guilt would stay with you a lot. You would either sleep much more or much less than normal. You would have fatigue, etc. So you need to have 5 out of those 9 symptoms, and that's when we give you a diagnosis of depression. Next slide. If you actually have depression, you are not alone, okay? 17% of the population will have a depressive episode in their lifetime. So 7% of everybody in this country has depression currently. Okay, so it is not something that is unusual. It's something that we deal with every day. There's a little bit of a higher occurrence in women and in men, but men are catching up in the last 15 years. And of course, if you have patients, if you have parents or grandparents that have had depression, you had a higher likelihood for depression as well. important is that depression can hit you at any given time point, okay? It can hit you when you're 20, it can hit you when you're 70, okay? And currently in the US, there's a little bit of a delay on when it first starts to when you get treatment the first time. But it's important for you to know that there does not need to be a reason for you to develop depression. It does not have to happen or co-occur with the death of a loved one. It does not have to co-occur with an additional stressor. It can happen completely out of the blue. It can happen that you have an event happening, but it doesn't have to be. Next slide. So what we are doing is, just click twice. What we are doing is we are looking at what happens when you are currently on medication and that's not working. So instead of going back to your primary care physician, to your PCP, or your you can actually contact us, and we will look at what studies we can have to, that we can offer you, where your regular antidepressants don't necessarily help, or you feel that your PCP does not feel comfortable sending you or giving you another antidepressant. Okay, so for us, usually it's anybody 18 and up. Next slide. And so right now, we have a study that is really exciting. You need to be clinically depressed, so that, and we will determine whether you're feeling clinically depressed, but we also need to already be on a medication that's any antidepressant for at least 8 weeks of treatment. Okay, if you're willing to come to our site, to Emory, and if you're willing to be randomized in a trial, next slide. Next slide. Okay, click one more time. Then we actually are doing a psilocybin study right now in treatment-resistant depression. So psilocybin, many people know about it, is actually magic mushrooms. So we are doing a trial where we give you psilocybin, those magic mushrooms, and do psychotherapy with you while you are on the magic mushrooms. Okay, you will get 1 milligram, 10 milligrams, or 25 milligrams of that drug, and we will accompany you while you are on your psychedelic experience. Okay, you will just need to come to see us about 10 times over an 18-week period. Next slide. And it's open to anybody who's 21 and over. So a lot of our studies in psychiatry, we usually have a cutoff at about 65 or 70. This study does not have an upper age limit. Okay, so if you are currently using on an antidepressant and the antidepressant is not working, which means that you are not getting 50% better than your normal functioning at work or at home, and you have failed 2 different antidepressants, then please come and contact us, and we will try to get you in the study. Okay, so you can have never have tried psilocybin before. That's our major exclusion criteria. So the FDA said, which is the Food and Drug Administration said, you cannot have had previous experience to psilocybin. And you can call this number below, 404-712-5063. That is my personal office number, and I will give you our a 24-hour number at the end. Next slide. Okay, so for people who actually have something that's called post-traumatic stress disorder, that is any kind of traumatic event that happened to you maybe within the last 10 years, but you cannot get those events out of your head, and it leads to a lot of let's say helplessness, intense fear. It leads to a lot of reduction of life experiences, and that could be any experience. So, example, you could have had a car accident, or the death of a loved one, or witnessing the death or injury of strangers. Any of those can actually contribute to you developing something that we call post-traumatic stress disorder, and that's one of our anxiety disorders. Next slide. So if you actually have a diagnosis of PTSD, or you think you have PTSD, next, just click 3 times, yeah, then we actually have right now a phase 3 randomized double-blind trial of brexpiprazole in combination with sertraline for people with PTSD. And that's interesting because both of these drugs are already FDA approved. And that's important because in research, we sometimes go ahead and try new drugs that have never been tried out before. And in this study, both of them actually have a good safety profile and are FDA approved. Okay. And if you find that you or somebody that you know have had a post-traumatic experience, then please have them contact us as well, because we are looking at a combination of sertraline, which is the antidepressant Zoloft, and brexpiprazole, which is actually Rexulti. And so this will take about 17 weeks. And we are really hoping that this will make a difference in people's lives. Next slide. Yeah, so for these, it's really important that you cannot currently have any pending litigations or be in court for disability claims. You cannot have any diagnosis of schizophrenia or other psychotic disorder, but we usually assess those as well. And the traumatic event cannot have occurred prior to 2011. So there's a 9-year limit to when the traumatic event occurred. But feel free to contact us, next slide, at any given time point, because we actually have we have clinical coordinators that can take your phone number and that can actually talk to you a little bit about which new studies you may be eligible for. So really important, just a little quick update. We do have a AAGPC study, which is we're looking at African Americans who have schizophrenia and bipolar disorder, and that's a long time study where we just take a little bit of blood and do an interview. But we are very excited that we are soon starting the Latin ancestry as well. So is everybody or anybody who has a Hispanic ancestry and has been diagnosed with schizophrenia, bipolar disorder, or no disorder, then we do an assessment as well. And then it's very quick and easy. If you've never done research before, it only takes about an hour to 2 hours. You give us a saliva sample or a blood sample and you'll be out of your way. And you kind of find out the first time how it is to be a research participant. And you get paid about $25 if you have no disorder and $50 if you actually have schizophrenia or bipolar disorder. Next slide. Okay, and all of these are just for you to, that are going to be in the handout. So I don't have to talk about these right now, but you have to you cannot be adopted to be in the study, but that's minor. Next slide. So this is us. So I'm Tanja, and this is my email address. You can email us at study@emory.edu. You can call us at 778-MOOD. My direct line is 404-712-5063. We have a website, emoryclinicaltrials.com. There's questionnaires that you can fill out, especially during these times. A lot of us are working from home, so we are not always answering our phone calls, but we get them into our emails. So whenever you call and leave a message, we will call you back the next time we're in the office. And I think that's it. So if anybody has any questions, I'm always here. And I saw that somebody asked for the slides. So the slides will be available after with Cornelia.
Yes.
And if you have any questions, feel free to ask any questions.
Okay. So Dr. Kowski was on back in June, and I'm just wondering, are you all seeing more patients during this time of stress and everything that's going on with the pandemic? Are you seeing an increase in patient visits?
And depression? Yes and no. So we are not seeing more patients, but that's because Emory as a provider is pretty booked out. So we just hired more psychiatrists. So we have 5 more psychiatrists in our department. So that means, yes, we do see more, but we've always had a lot of psychiatric need in Atlanta. And so I'm not sure whether the increase is now due to COVID or because we had to have 5 more psychiatrists anyway. So what we do see is we do see a lot more uptick in requests for psychiatric trials, and that is because a lot of people are losing health insurance and then can't afford the medication anymore, because if you don't have health insurance, your medications can be quite expensive, and you have to see psychiatrists every 6 months in order to get a refill, and so that can add up if you don't have insurance. But the good thing for clinical trials, or the good thing about our program, is that you actually don't have to have insurance, and we will always try to get you signed up for, you know, a program, patient assistance programs that maybe that is from pharmaceutical companies, etc. So we are trying to get you the help that you need as at little cost possible.
Okay. And one final question. What you mentioned family history. Is there, do people with family history have a predisposition for depression?
Yes. So we know you have a 1.5 to 3 point increase in your risk. So so that means that if you have a parent or both parents who have had depression, then your risk is elevated. Okay, it's not inevitable that you're going to have depression, but it is definitely elevated, and so it usually is good if you have a family history that you learn resilience strategies quite early on, because most likely you will have at least one episode. And the problem is, if you have had one, you have about a 50% chance of having another episode. If you've had 2 episodes, we think you have about a 75% of having another episode. And if you have 3 or more episodes, you will almost 100% you will have another episode. So that's why we're trying to catch people early. You know, if you feel that there's depression coming on, go to your PCP. An antidepressant is not expensive. It will cost you about $4 a month, but the trajectory is so much better, and it will keep you from having another episode, and that is detrimental maybe to your future mental health.
Okay, and one final thing, there are about 13 people that have called in and they can't see the slides, but we will send out an email. Will you tell them the website where you said you can fill out the questionnaire?
Yes, it's www.emoryclinicaltrials.com. So emoryclinicaltrials.com.
All right. Thank you so much. This was very informative. You all have so much activity and interventions going on, so we encourage people to get involved. And there's another question in the chat. So we're going to move on to our next presentation. Dr. Glenna Brewster is going to be sharing an update about a trial that she currently has that is active. And Dr. Glenna, give me 1 second. I'm going to try to make sure I pin your video so we can see you.
Right.
All right, there we go.
All right. So thank you so much, Cornelia. And my study currently is sleep disturbance as a challenge for persons living with cognitive impairment and their caregivers. Next slide. So what really is sleep? And sleep is a period of inactivity and restoration of mental and physical function. So a lot of times we might think that sleep is one of the things that we give up, but it should be one of the things that we prioritize because of what happens during sleep. And during sleep, really, we alternate between something that we call rapid eye movement and non-rapid eye movement. And during these 2 stages, the function of these is to integrate new memories and existing knowledge, but it also helps to restore brain chemistry to a normal balance. And current research is showing us that it also helps with the getting rid of the beta amyloid and tau that we usually build up during the day that is associated with Alzheimer's disease. And we recommend sleep for between 7 to 9 hours nightly. The average American these days, about 1/3 actually gets less than 7 hours of sleep. And research has shown us that For caregivers or care partners, about 66% of them actually report that they have some type of a sleep disturbance, so that maybe they have issues with falling asleep, issues with staying asleep, issues with waking up very early and waking up multiple times throughout the night, and that could be for a variety of reasons. And about 71% of persons living with cognitive impairment actually experience some type of a sleep disturbance. Next slide. So specifically, when we look further, we see that for persons living with cognitive impairment, that many times they may actually have day and night sleep pattern reversals. So that means that during the day, they tend to sleep a lot, and then at night, they tend to be awake. And when they're awake, then as a care partner, you're also awake. So one of the things we often encourage is to find activities for the person living with cognitive impairment to do during the day that will keep them awake so that at night they can sleep. And then they oftentimes have frequent nighttime awakenings. And you know, sometimes it's okay to awake at night. We might want to use the restroom and we wake up and we go to the restroom and we fall back asleep. But sometimes when we awake at night and we have issues falling back asleep, we might lay in bed for 2 and 3 hours before actually falling back asleep. And then we see in persons living with cognitive impairment, increases in daytime sleepiness and napping. And for the caregiver or the care partner, we see that, you know, multiple nightly awakenings, and it could be that they need to use the restroom, or it could be, we talked about stress earlier. If you're stressed and you have a hard time falling asleep, you're thinking and worrying about all these things that you might have to do as the caregiver or the care partner. But it could be also that you're waking up to help your loved one as they wake you up for assistance. They have shorter sleep duration. So many times what we've seen happen is that you'll help the person and assist them so they're in bed, and then the caregiver might stay up and they're doing all these other things that they might not have gotten to do during the day, or they might just take some time for themselves. And when that happens, then they also awake earlier in the morning, so they have a shorter sleep duration. And they take a longer time to fall asleep. And there are many reasons for this. So it could be that they're laying in bed and once more they're thinking about all these activities and their responsibilities and the future and everything else that keeps them awake and makes it hard for them to fall asleep. And then inconsistent sleep and wake time. So one night they might go to bed 8 o'clock, the next night it might be midnight, the next night it might be 9 o'clock, and then the next day they awake at random times also. So this inconsistency might be contributing to their sleep disturbances also. Next slide. So what my team and I want to do is, there is this tested intervention called cognitive behavioral therapy for insomnia, and it has been shown to improve outcomes for insomnia in persons from different populations. So it's been done with persons living with cognitive impairment where they were the only ones participating in the intervention, and they found that it actually improved their sleep. And it has been done in veteran students, a lot of different populations, and we've shown that it's worked. But what we haven't done yet is actually doing it in the dyad. So that a dyad means that both the person living with cognitive impairment and the caregiver participates in the intervention. And initially we were going to do some of it in person and some online, but with COVID, we've decided to go fully online. So this is a fully online 4-week intervention, and there are different things that you do each week. And the sessions each week are about an hour. So we do stimulus control, we provide something that you can do relaxation, we talk about sleep hygiene, sleep compression, and cognitive therapy. So those are some of the main things that we discuss for the 4 weeks. Next slide. And the aims of the study, because it's, you know, something like this hasn't been done in caregivers / care partners and persons living with cognitive impairment before, we want to see whether it's feasible. So we want to see whether or not both people can do it, how they reacted to it, whether they liked it, those things. And we want to find out if it's acceptable. So is it something that they think that they can do? Did it help them? Those are the things that we'll be asking about. And then at the end, we will examine the efficacy, so whether or not it helped both members of the dyad as a group and as individuals, whether their sleep quality, sleep efficiency, the amount of time they took to fall asleep, how much time they were awake at night. whether or not it helped improve those, whether there were any changes in those outcomes. So those are the things that we'll be looking at for the Dyad. Next slide. And to be included, we want you to be, so there'll be both people who will be participating, the caregiver, the care partner, and the person living with cognitive impairment. Living in the same residence, we're not requiring that you're sleeping in the same bed, but we want you to be living in the same place. Both experiencing some type of a sleep disturbance and on stable dose of medications and can tolerate and wear a wristwatch device. Next slide. So the wristwatch device is actually called an actigraph, and that will be how we're going to measure objectively your sleep. And we wear that, we say your wrist, and we're going to have you wear it for 6 weeks. The reason we say 6 weeks is that the intervention itself is 4 weeks, but 2 weeks before that, we are going to actually assess what your baseline sleep is. So you're going to be wearing it for baseline and then the 4-week intervention. And during that time, we're also going to have you fill out a sleep diary. So the sleep diary is where you subjectively complete the time you go to bed, the time you wake up, how much time you took to fall asleep. Some people use sleep medications and we think that that's important. So you put those in, the number of awakenings you had during the night and your sleep quality. And that also will be completed daily for 6 weeks. Next slide. And during that time, we're going to have 3 main data collection visits. So baseline, we're going to have some questionnaires that we ask you to do. So earlier presenters alluded to stress and depressive symptoms. So those are some of the questionnaires. We have a questionnaire for stress. We have a questionnaire for depressive symptoms. We're doing a mini cognitive screen and just a few questionnaires and tests about what the caregiver experiences and what the person with cognitive impairment experiences. 1 week post-intervention, we're also redoing the same questionnaires because we want to see whether or not there was any change associated with the intervention, and we're going to do an interview. So that interview will allow you to tell us what you liked, what you didn't like, how we can improve it, what we can change potentially, and just to give us your honest feedback about your experience during the intervention. And then 3 months post-intervention, we're also going to do questionnaires. So we want to see whether or not the intervention was effective after a 3-month period of time. It will just help us to see whether or not there was any lasting, as it were, or long-term effectiveness or efficacy of the intervention. And for your participation, we recognize that this does take time from you both to participate. So each person will earn up to $100 for your participation. Next slide. All right. So if you are interested in participating, then I am the PI for the study. You can email us. There's a research coordinator also. Her name is Rinwa. And you can email us at drbrewsterlab@emory.edu, or you can call us 404-712-9164. And if you're going to send us an email or call us, we will appreciate it if you include your name and your phone number, so we'll know who you are and we'll call you back and tell you a bit more about the study. So I think
Excellent.
that is it. Thank you.
So Dr. Brewster, is this opportunity also available for sundowning patients?
Yes.
Yes.
So what we're saying is that if the person is able to follow directions, then that would be important. But so we want mild cognitive impairment to about early stage dementia, and even some people with early stage dementia do experience some type of a sundowning. So if they're sundowning but early stage and they can follow instructions, then they would qualify along with the caregiver or the care partner.
Okay. And you have studied sleep, and here's a good question. What is good sleep hygiene? What does that look like?
So there are 2 things when we talk about sleep hygiene. Sleep hygiene has to do with, when we talk about keeping ourselves, as it were, hygienic. So that means brushing your teeth, taking a shower, ensuring that your clothes is clean, those kind of things. So for sleep, it's ensuring that you're doing the things that would promote good sleep. So for us, we say it is when you have your bedroom is dark and you keep it at at a good temperature, and you don't drink coffee, especially if you know that it keeps you awake after a particular time, and you don't have your phone or things with bright lights in bed at least 2 hours before going asleep. A lot of us tend to like wine. If you're drinking wine, then alcohol has a way of making you feel sleepy initially, but then you get light sleep after that. So trying not to drink alcohol or wine within 2 hours of going to bed, and not smoking, because nicotine also has the same effect within 2 hours of going to bed. We love our pets, but to the extent that we can keep them out of our beds, that might also help to improve our sleep. So doing things that would promote our ability to get good sleep are the things that we talk about when we talk about sleep hygiene.
Okay, and what is sundowning? That is a common term. What is sundowning?
So when you think about the day, the time that the sun goes down is about the time where, for people living with different types of dementia, we'll see changes in behaviors. So sundowning is actually the changes in behaviors that we might see in persons living with Alzheimer's disease and other dementia as the day gets to a close or comes to an end. So, around 3-4 o'clock, they might start getting a bit agitated, a bit anxious, just a change in how they normally act and behave. And, it's for us to come up with different things that we can maybe to entertain them, or do we need to expose them to more sunlight, putting on some light in the room, finding activities for them to do during that time, things that they might like that we can have them do during that time to maybe reduce the experience of that change in behavior we see as the day comes to a close.
All right. Okay, this sounds like an awesome study. I hope you get lots of calls.
Thank you. Me too.
Again, a PDF with all of their contact information will be provided. So we're going to close out.
Cordelia, I also wanted to say one thing. So it's not limited to Atlanta because it's virtual. So anywhere in the U.S. really we'll be mailing the packages to. So if you know somebody else somewhere else in another state who might be interested, you can feel free to share it with them.
Oh, wow. Okay. Well, that's enlightening considering COVID and everything. We can do research. Our research does not have boundaries and limitations to just the state of Georgia. Thank you so much, Dr. Brewster. Okay.
Thank you.
So as we transition and get ready to close, we're going to invite Whit Morgan to come on. And again, you can be an active research participant with our Emory Healthy Aging Study. We welcome participants. We'd love to have you join us and be a part of this study. Hi, Whit.
Hey, how's everybody doing?
We are well. Thanks for coming back and being with us every week.
Always, always. If possible, I would like to be able to share my screen just because I know that there's probably some new folks on here that may or may not be quite up to speed on what the Healthy Aging Study is. And we've talked about it a little bit here on participating in research. And so being able to join research, especially during a time of quarantine, is kind of an interesting concept. And it's something that we're really excited to be able to bring about here with the Emory Healthy Aging Study, because this is actually a longitudinal research study that you can participate in from the comfort of your couch or any bedroom in your house if you want. The only thing that we're needing is that you have an internet-capable device, you are over the age of 18, and that you can read and understand English. Because what we are asking our participants to do is just complete a health history questionnaire once a year. It takes most people about 30 minutes to do it, and then once you've completed it, we'll actually remind you each year to update any of the information that might have changed. So it's a really easy way to get involved in research, especially if you haven't done it before and you kind of want to dip your toes in the water. This is a really great and unique opportunity. And because it's done entirely online, hopefully y'all can see my screen here. Our website, healthyaging.emory.edu, and I'll drop that in the chat box here in a moment, is actually where you would want to go to navigate just to kind of learn a little bit more about the study itself. But we hit this big yellow button up here at the top, And if you actually click on that, it's a 4-step process where you go through, you'll register just basic name and information, and you create your account. And then it'll actually walk you through a virtual consent. We'll get a little bit more contact information in case we have some questions. And then, of course, the final step in there is completing the health history questionnaire. So you can do this on your computer, you can do it on an iPad, you can even do it on your cell phone. Generally, most people seem to have the best user experience when they're using a computer or maybe a tablet with a bigger screen on it, just so that you can read the fonts and engage with it more easily. But some of the other things that I wanted to kind of talk about on a high level, we talked last week about some of our milestones that we have reached as we've gone through this research study here the past 5 years. And a lot of that information is actually available on our website underneath our annual reports tab. But one thing that I wanted to kind of showcase I didn't get to talk about a whole lot last week was some of this really cool content that we've developed for our participants that is available in last year's annual report for the aging study. And again, I'll drop my contact information on the chat box before we close down in case you want to reach out, and I can send it to you directly. But we worked really hard to go through and kind of curate different pieces of content for our participants that might be, helpful then. Now, since we're now in quarantine, it's actually become a little bit more relevant. So things like, for example, we're talking about staying fit, staying healthy. When we have John Lewis go through these awesome exercises at the beginning of each session, we developed a piece of content just for stretches that you can do as you get older. And we want to be cognizant of, mobility limitations or potential environmental hazards. And so some of the things that we've gone through are looking at different types of exercises and activities that you can do at home, for example, with, using a chair to do a thigh stretch just to ensure that you're being a little bit more safe. Or if you're somebody that likes to eat, I'm definitely one person that likes to cook a lot because I like to eat a lot. And so I love to explore these different recipes for a healthy brain. And it goes through and talks about different types of nutritional aspects involved with this. A lot of this is based off of the Mediterranean diets and the heart diet, or the heart healthy diets. So when you're going through and looking at these ingredients, there's descriptions in there. There's a lot of information about the benefits of each one of these. And so we wanted to make sure that, our participants are aware of the content that is available as we're going on a week-to-week basis during this quarantine. In the meantime, though, like I said, if you have any questions about participating in the Emory Healthy Aging Study, I'm going to drop my email into the chat box, because one of the other cool things about the Emory Healthy Aging Study is that we use it also as a means to partner with other researchers to analyze data. And we also use it as a means to identify potential participants for one of our really big sub-studies that is focused specifically on identifying the biomarkers that will help us identify or predict who's going to develop like Alzheimer's disease and dementia. And so that's called the Emory Healthy Brain Study. And I just tell you that because in the event that you join the Emory Healthy Aging Study, and it looks like you might be a qualified candidate for our sub-study, one of our research coordinators is going to be reaching out to you about that. So we just wanted to make sure that you're aware that, if you are looking like you might be a great candidate for our Alzheimer's study, somebody might be reaching out to you about coming in and actually participating, doing some cognitive testing, getting some biosamples, and actually going through an MRI. And let's see, I'm not too far over, am I? We're at 3:08. Okay, I will drop that into the chat box here, or my information, as well as our web address in case anybody has additional questions.
So how many people have signed up for the Healthy Aging Study?
So far, we have over 30,000 people that have registered for the Healthy Aging Study, and more than 16,500 people have gone all the way through and completed their health history questionnaire at least once.
Wow. And this study has been around for what, only?
Going on 5 years now.
5 years, wow.
Our goal is 100,000 registrants. So we are just over 30% of the way to our overall goal.
Excellent. And what is the goal for the Healthy Brain Study?
So for numbers, we're looking for around 3,000, or I think it's 3,000 people. That number tends to fluctuate a little bit depending on participation rates. But the really big goal for the Healthy Brain Study, our Alzheimer's focused study, is that we're wanting healthy participants. So if you have an MCI or an existing Alzheimer's diagnosis, for example, you would not be eligible. But we are working with younger and healthy individuals over a longitudinal period. So every 2 years, we're going to ask our participants to come back in for further testing. But our goal is to identify the biomarkers within our bodies that are going to help us identify who's actually going to develop Alzheimer's disease. And if we can identify who's going to develop that, that will really set us up better to be able to potentially intervene with the development of those diseases.
And what if someone started this study online, but they didn't get all the way to the end? Do you pick back up where you left off? Do you start over? How does that work?
Great question. So it can be a mix of both depending on when you register. So if you registered, for example, 2 or 3 years ago and you started the health history questionnaire, it's very likely that you would actually have to restart the questionnaire because we have updated it since then to make it more user friendly. And in the process of that, just technologically speaking, it reset some of the progress. But for example, if you started on this, let's say 6 months ago, or even if you didn't make it all the way to the HHQ yet, if you are having trouble logging in, back on our website next to the join the study button, there was a login button. So it's just your name and your email address, and a password you would have set. If you think you started that process and you are unable to log in, I put my email in the chat box here. Just send me a direct email. Say, hey, look, here's the address that I normally use. I think I signed up. Can you check that for me? And I'll be able to let you know exactly where you are in the process.
And would you tell us your email address and the URL for the Healthy Aging for our audio only audience?
Yep. So I just put those in the chat here. So let me see if there's another place that I can also put it. Nobody answered. I put it in the actual answer section. So it is in the chat. Let's see. My email, though, just in case you're looking for it, is jefferson.morgan@emory.edu. And our email, or not our email, but our web address is just healthyaging.emory.edu.
Okay. And what about is there like an upper age limit, or is this from 18 to age 99?
So there is no age cap on the health history questionnaire or for the healthy aging study. So as long as you're over the age of 18, once you cross that threshold, anybody of any age is able to join.
And let's see, another question. If we signed up, would you use our results from the test that was used in a previous study if that was terminated early due to a problem?
So the way that would kind of work for the healthy aging study, it's possible that we might use some of the information. It depends on what that information is. So in weeks prior, one of the things that I went through, it was some of the demographic or just the general information that we collect in our study. And a lot of that is really high level. It's going to be more demographic, but we're also going to ask you more specific questions about, like, do you have any existing health issues or any existing diseases or chronic problems? How much exercise are you getting? What are your eating habits? How many cups of vegetables do you eat in a week, for example? Those are the types of questions that we're looking at on the health history questionnaire. And if you have, for example, an underlying health condition that was potentially discovered while you were going through a previous study, that's where it might be relevant and you can put that information in. But we're not necessarily going to reach out to like a previous researcher to say, oh, well, we need these specific test results, because we're very, very cautious about making sure everything's done in a very structured environment. So we want to make sure that, we are going through, we're not entering a whole bunch of extra variables that might potentially throw our data off.
Right. And, there's a question for you, Glenna. Does sundowning occur in other times than in the evening?
Dr. Hepburn, do you have the answer for that? I would say that it is not impossible because of a change in circadian rhythm, that definitely there are behaviors that we can see that are not necessarily in the afternoon. So with this disease, nothing is impossible. But I will also look further into that. And if Dr. Hepburn has anything else to add.
No, I'm going to defer to you on that, Glenna.
Okay. Whit, I
Yes.
want to see your face.
Let's see my face.
Yes, your picture is up.
See, let me turn my lamp.
You don't have to. I'm just, we're being a little lighthearted. So what question is for any of our researchers as well? There you are. Hello. Good to see you. And Dr. Dr. Brewster, Dr. Hepburn, Mrs. Crow, if you want to all come on. They're asking, do we sell our data to outside groups? How do you share data with other researchers who you are partnering with? Can you tell us how that works?
Right. So sometimes we do partner with other researchers. There is a process that we go through anytime somebody is interested in partnering with us and utilizing our data. They think of it kind of like an application process. They would more or less fill out our online application forms that come to us that allow our researchers to review the proposed partnership, what they expect to do with the data or what they're looking for. And ultimately, it allows us to kind of vet the intentions. And so if we've decided then to partner with one of our other researchers, we obviously will share the data that they're looking for. But the important thing to realize for the data is anytime that we're sharing it, that it's always de-identified. So we are not sharing any kind of personal or what we would call PHI, personal health information that would link you back to that specific piece of data that we collected.
Glenna, Tanja, any other remarks?
What it said, and before we can do that, then we also have to get approval from the IRB to be able to share data. But as Whit said, it will be de-identified, so nothing that could identify you.
Exactly. It's the same with us in psychiatry. So de-identified data means we're taking your name, your age, your date of birth, your address, your zip code, and everything out. And all that's left is like 53-year-old female with the diagnosis of depression. So that's de-identified PHI. And that's what we sometimes share, but usually we need to have an agreement with the IRB in a separate study.
Mm-hmm. Excellent. Okay, I don't see any more comments or questions in the chat.
Can I say, I've looked online and most of the things I've seen says that it happens towards the afternoon as the sun is setting, as the sun is going down.
Mm-hmm. Oh, perfect. Okay. All right. Well, it is past our time. We thank each of you for joining us. We will leave the poll up a little bit, and then the participant satisfaction survey will also go out as well. Remember, be back here next week with us. We are going to be featuring John Lewis. He's going to get us pumping and going and moving and get our bodies all worked up. And then we're going to hear from the DeKalb County Board of Health, because it is adults do get vaccines. So we want to know what that schedule looks like, because we want you healthy. We want, if you're healthy and you're staying healthy, we want to keep you healthy. And then if you have games that you would want to participate in on this platform, you can send those to us. I know we're definitely going to play some trivia. We're definitely going to do like name that tune. And if you want to have your video on, or if you want to keep your video muted, or if you just want to watch and listen, we're happy to have you. But we're giving our experts the week off. We've been actively doing this since March 31st, and it's a big production. And we really appreciate you all for being here with us every week. Round of applause to everyone who joined us today. And all right, thank you guys. We will see you next week.
Thank you.
All right.
Thanks, y'all.
Bye-bye.
jamming with a live band with the mic in my hand, damn, but it's almost the end, so I have to finish my words and never swerve, cause I don't drink and my breath don't stink, and I think with my third eye word, I like to hang with liquid to the soul, like I said before, I never fold in the game, I'll never be a lame, and it'll always stay the same, rap is falling in my veins, like my man said, on the drums, on the bass, on the guitar, I like to hear him strum, I like to run with my coke, I like to get stripped like a cat, I like my music always stay fat, and I like it like this and like that, and like this was so good with it, that's why they do it fluently, and I'll be doing these rhymes, I mean the vocals on the instrumental, and everything I do is freestyle, fundamental.